Psoriasis. Psora is a Greek word which means itch. Psoriasis is a common but complex and multifactorial skin disease. It is a chronic inflammatory skin condition that involves hyperproliferation of the keratinocytes in the epidermis, with an increase in epidermal cell turnover rate. Now, what are the causative factors? Has both genetic basis and non-environmental triggers such as cold, trauma, infections, alcohol intake, and some drugs like iodide and steroid withdrawal. Injury or irritation to normal skin tends to induce lesions of psoriasis at their site, and obesity also worsens the psoriasis. Now, clinical features of psoriasis. Often there is no symptoms but itching may occur and be severe. Favored sites are extensor surfaces, scalp, elbows, knees, palms, soles, nails, and occasionally flexure surfaces of axilla and inguinal region. Lesions are red, sharply defined plaques covered with silvery scales, and there may be fine stippling or pitting of nails. It is highly suggestive of psoriasis. Pink or red intergluteal fold may be there, and there may be associated arthritis that is most commonly distal or oligoarticular. Conjunctivitis or blepharitis may be there. Now, types of psoriasis. Common types of psoriasis include psoriasis vulgaris. It is the most common type, involves scalp, extensor surfaces, genitals, umbilicus, lumbosacral and retroauricular regions. Then plaque psoriasis. It affects extensor surfaces of knees, elbows, scalp and trunk. Guttate psoriasis. Predominantly on trunk, appears suddenly 2 to 3 weeks after upper respiratory tract infections with group A beta hemolytic bacteria. Then inverse psoriasis on the flexural surfaces of armpit and groin, under the breast and skin folds. Pustular psoriasis on palms and soles or diffusely over the body. Erythrodermic psoriasis covers nearly the entire body surface, red skin and diffuse peeling scales. Scalp psoriasis. It affects 50% of the patients. Then nail psoriasis, it may be indistinguishable and prone to develop onychomycosis. Psoriatic arthritis affects approximately 10 to 30% of those with skin symptoms, usually involves hands and feet. Oral psoriasis may present as severe chillosis. Then eruptive psoriasis, it involves upper trunk and upper extremities in younger patients. And at the last, napkin psoriasis in children's diaper region. Now, what are the differential diagnosis? Diagnostic features are combination of red plaques with silvery scales on elbows and knees with scaliness in scalp, or there may be nail findings. Now, difference between psoriasis and atopic dermatitis. In psoriasis, lesions are well demarcated, and in atopic dermatitis, lesions are poorly demarcated. In psoriasis, mostly affects extensor surfaces, while on the other hand, it affects flexor surfaces in atopic dermatitis. Other differential diagnoses include intertrigo, candidiasis, onychomycosis, psoriasis rosea, reactive arthritis, seborrheic dermatitis, allergic contact dermatitis. Now, what is the workup for the diagnosis of psoriasis? Diagnosis of psoriasis is clinical, but lab studies may include the following. Rheumatoid factor is negative, ESR is usually normal, uric acid level may be elevated, fluid from pustules is sterile with neutrophils. Perform fungal studies to differentiate candidiasis. Conjunctival impression cytology, punch biopsy of skin act as the confirmatory workup procedure. Histologic findings are regular acanthosis of epidermis, parakeratosis, it is presence of nucleated keratinocytes in the stratum corneum. Kojoge, spongiotic pustules, and microabscesses. Management may involve topical medications, systemic medications, phototherapy, stress reduction, climatotherapy, adjuncts like sunshine, moisturizers, and at the end diet with weight loss can also help treating psoriasis. Pharmacotherapy. Topical corticosteroids are used such as triamcinolone acetonide 0.025 to 0.1% in cream form and betamethasone 0.025 to 0.1%. Ophthalmic steroids include prednisolone acetate 1% ophthalmic, dexamethasone ophthalmic solution. Then intramuscular corticosteroids like triamcinolone. Intrarenal corticosteroids can be useful for resistant plaques and for treatment of psoriatic nails. Keratolytic agents are used like anthraline and urea. Vitamin D analogs are used, which include calcitriol ointment and calcipotriene calcipotriene and betamethasone topical ointment. Topical retinoids, for example, tazarotene, aqueous gel or cream can be used. Methotrexate used as antimetabolite, used for as long as it remains effective and well tolerated. Immunomodulators are used like tacrolimus topical 0.1%, cyclosporin, alifacept and ustekinumab. TNF inhibitors are used like infliximab, etanercept and adalimumab. Phosphodiesterase 4 inhibitors like apremilast is used. What are the non-drug therapies? Include light therapy, stress reduction, biofeedback therapy, climatotherapy, sunshine and moisturizers, oatmeal baths, punctal occlusion and ocular lubricants for keratoconjunctivitis sicca. Now what are the surgical options? Ocular complications like trichiasis and cicatricial ectropion usually require surgical treatment. Corneal meeting vascularization may require lamellar or penetrating keratoplasty.